Hello, good morning everybody. Welcome to the March Health and Wellbeing Board. I think we can safely say, hopefully, that spring is in the air. I know we've had a bit of rain over the last couple of days, but certainly days are getting lighter. I'm going to start the meeting off by doing some introductions, if that's okay with everybody. So, a quick reminder that any observers, that there is an opportunity on the agenda to ask questions, but they obviously must relate to anything that's on the agenda itself. So we'll just do some introductions and we'll start with this side, top row.
Simon Nazir J. Forge, Public Health Lead, City of Doncaster Council.
Thank you.
Cynthia Ransom, Ward Member for Sprotborough.
Tony Illman, Chief Funding and Information Officer for Doncaster Culture and Leisure Trust.
Claire Hewitt, PA to Director of Public Health.
And you two on the tip, Mr. Brown, do you want to say good morning?
Yeah, Tim Brown, community activist in Doncaster. Thank you.
Morning, Nick Abbott, Group Manager for Doncaster District, South Yorkshire Fire.
Good morning, Claire Henry, Public Health Principal at the City of Doncaster Council.
Hi, Romana Shafiq, a Public Health Degree Apprentice at the Council.
Victor Joseph, Consultant in Public Health, City of Doncaster Council.
Good morning, I'm Rachel Leslie, Director of Public Health at City of Doncaster Council.
And we'll now move on to the top row, Nabil.
Morning all, Nabil Al-Sindi, I'm a GP and I'm Place Medical Director for Doncaster at NHS South Yorkshire.
Hi everyone, I'm Councillor Sarah Smith, Cabinet Member for Adult Social Care.
Morning everyone, James Woods, Chief Exec Citizens of West Doncaster.
Hi, Fran Joel, I'm a Chief Exec of Health Watch.
Hi, I'm Kelly Hicks, representing the community and voluntary sector.
Morning, I'm Chris Margrave, I'm Chief Executive at Ledger Homes.
I'm Phil Holmes, I'm the Director of Adults, Wellbeing and Culture in the Council.
Good morning, Rihanna Nelson, Executive Director for Children, Young People and Families in the Council.
Fantastic, thank you. And we've also got a gentleman at the back. Do you want to introduce yourself, sir? Okay, thank you very much. So, apologies for today's meeting have been received from Richard Parker, Toby Lewis, Councillor Elaine May Ball, Anthony Fitzgerald, Dan Swain and Glynis Smith, Councillor. Are there any other apologies at all that we need to record today?
I've received apologies from Laura Sheridan from
Okay, thank you. So there's no substitutes for any board membership today as far as I'm aware? No? Right, thank you. So obviously, we're not expecting a fire practice today. If an alarm sounds, please leave the building by way of the fire exit through the doors to the rear of the chamber. When you have left the chamber, proceed down the stairway and exit through the emergency exit on the ground floor. If there is anybody with mobility issues, please wait in the refuge area at the top of the stairs where the emergency evacuation lift is located, and use the intercom situated to the left-hand side of the lift doors to call for assistance. The designated assembly point is a public square in front of CAST, beyond the fountain, as you can see outside. And I would like to inform any members of the public and press that today's meeting will be audio-visually recorded. By entering the Council's chamber, you accept that you will be recorded and your images retained and broadcast by the Council on its website and on to YouTube. If anyone intends to record or film any part of today's meeting, please ensure that does not disturb the conduct of the meeting and that you only focus on recording those people participating. We'll now move on to item 2, which is Chair's announcements, 5 minutes. There's no announcements from myself, so we'll go straight on to item 3, and this is the exclusion of press and public. There are no items on today's agenda where the press and public are to be excluded. Moving on to item 4, declarations of interest. Does anybody have a disclosure of pecuniary interest or any interest in declaration to declare in relation to the business of today's agenda? If so, please declare it now and complete a declaration form available from Caroline Martin, Governance Services. Is there any declarations? Okay, thank you very much. We'll now move on to item 5, which is public questions. We've got 15 minutes for public questions in total. There is a standing item on board agendas aimed at providing an opportunity for members of the public to ask a question or to make a statement. Please note that questions or statements should relate to an item of business on the agenda for today's meeting. So are there any elected members or members of the public attending today and this meeting who would want to put a question to the board? Mr. Brown.
Sorry, let me get my iPad working. Yeah, thank you, Chair. I'm here once again, and it's something that I've raised over a number of years, and that is my lived experience of racism in Doncaster, and the fact that, you know, I've been coming here for many, many years. I'm an old man now, and I see no change. I just see the same rhetoric. We come here, we raise issues, and I'm talking about 30 years. I'm not talking about 3 months or what have you. I'm talking about 30 years of raising legitimate concerns of racism and how that impacts on my family, my community, and nothing really has been done about it. I came here in good faith at the last meeting to raise concerns about the BME Health Needs Assessments. The 2 distinct questions that I asked was around the extent of the engagement of people who look like me. In the report, it talks about Caribbean community. Caribbean community is not an homogeneous group. I lead on something called Doncaster African Caribbean Support Group, right, which is one of a number of Caribbean groups in Doncaster. I would have thought somebody would have had the courtesy to engage with us as an entity so that the legitimate concerns that we have raised over a number of years can be addressed, right? I've contacted Dr. Joseph, no response. I've contacted the chair, no response. Contacted vice chair, no response. Contacted Director of Public Health. She passes me on to Damien Allen, no response. Where do I turn to? What do I do? You know, who's accountable? Yeah? There's people in this room who are getting paid a lot of public money. Where are their commitment to racism or anti-racism? Why is it that I have to come here to be humiliated year after year after year when nobody in this room can answer me a simple question? Since we've had this BME Health Needs Assessment process, what improvements has been made? Surely that's a legitimate question. Why is it that nobody can answer? You know? I mean, you know, I'm not the problem, yet I'm the one who's so-called put under a SPOC. A SPOC is a single point of contact. It's used to stop people like me from raising concerns, right? Ironically, the former mayor of Doncaster, who sees the injustice of all of this, a guy called Peter Davis, has wanted to reach out to the council and said, what are we doing with this SPOC? He's been ignored. This is the kind of injustices that are taking place. If you want to put me on a SPOC, right, and label me with these racist tropes, black people are aggressive, angry, and all this kind of nonsense, then let's have a proper process so that we can, you know, so that at least I can articulate and say, well, come on, hang on about it. Hang on a minute. that suggests to me that racism is not taken seriously in Doncaster. Because, you know, if it was, those issues, what he raises, which corroborates the matters that I've been raising and other people have been raising for a number of years, have still not been addressed. And then since then, we've had a situation whereby our most vulnerable black girls at Hesley Children's Home has been subjected to horrific abuse, right? And you might say, well, what's that got to do with Doncaster Council? It's only when you read in the report that people who cared for those girls contacted Doncaster Council, the Lado, over 69 times on 69 separate occasions. It's in the public domain. I'm not making it up. Nobody did anything about it, right? Nobody did anything about it. And I, as a parent, I've got a daughter now who's at Loughborough University. You know, how can we allow women's hair to be just cut off and not do anything about it, not come out to the community and say, do you know what, lessons have been learnt or what have you, you know, and that. Now, I know people are looking at me and thinking, oh God, I wish you would shut up. I'm not going to shut up. I'm not shutting up. Because as I say, I've seen how racism in Doncaster impacts on black people who look like me, right? My ask for this health and well-being board is to do something about it, right? Is to engage with those of us who are interested. It's unacceptable for Dr. Joseph to come, and I'm not just blaming Victor, as I say, me and Victor, we shared an office together. He's in a very awkward position as a black guy, right? That he's prevented, like many of the black people who worked for the council before, from doing the right thing. What I'm interested, though, is where's the learning? If we don't address those issues, then we have a continuation of racism and its impact. I'm coming to the end, Chair, because I know you're looking at me and thinking, oh God, right? Even at the full council meeting, I think I was in this chamber, 19th of September 2024, right? There was an acknowledgement of racism, right? It's on YouTube. Again, I'm not making it up, right? How was those issues being addressed? It's not reflected in any of this, right? Nobody's come out to those of us who are really interested to say, do you know what? We're acknowledging the racism, right? We need you because you've got the lived experiences to help us address those issues. That's never happened. And in that context, you then ask yourself, well, how are things going to get better? How are things going to ever get better in Doncaster? And as I say, I'm looking at people in this room who some of them have been around for 10 years, 15 years, or what have you. I'm looking at people in this room, maybe to make a pledge, Chair. Would it be reasonable to ask people like yourself, Director of Public Health, Victor Joseph, there's the Director of Children's Service, whose head's down as though I don't remember her, but I know of Rihanna for many years. She won't remember me necessarily. But is it not reasonable to ask one simple thing for people in this room to take a bit of a pledge, an anti-racism pledge? I can help them to understand what that might look like. I can help them to at least, you know, momentarily just think about what it must be like being a Tim Brown, who's having the sorry, Chair, I'm just coming to the end, you know, but thank you for indulging me. But as I say, you can see I'm passionate about this. this really hurts me, right? And that I don't want to get emotional, and I shouldn't have to, right? You know, why, you know, as I say, Councillor Ransom knows of me for 20 years or even longer, right? And that. And it pains me. So I will shut up. I will come to the end, but I just want something to happen. I want people in this room to, if nothing else, think about some kind of anti-racism pledge, right? But more importantly, engage with those black people, whoever they are, in Doncaster, black minority ethnic people who are interested in racism and the impact that might have on their health and well-being. And I don't think that is too much to ask. My name's Tim Brown. I'm on email, I'm on Facebook, I think, or what have you, or my daughter can get me on there. My email is timtabrown@aol.com, but we can work together to progress anti-racism in Doncaster. Thank you, Chair.
Okay, thank you, Mr. Brown. That's fantastic. I suppose just addressing some of your comments there, there's a couple there that we just need to clarify. That there is, as you've quite rightly said, there is currently a single point of contact in place, which is a SPOC. Now, my concern is, if it is a concern, and obviously you've highlighted a concern, is that if you are contacting officers in terms of getting information around actions or anything that's happened, and that's not being forwarded back to you through the SPOC, that's something that I'll personally chase up, because that should happen. And I believe your single point of contact obviously is Damien, the Chief Executive, where that's concerned. So if you have requested information, or if you have sort of like sought information, or you've asked a question as such, that's something that you should be afforded to. And if that's not happening, that's something that I'm quite happy to sort of like take up. In terms of Esley, obviously you mentioned Esley where that's concerned. The investigation is still ongoing with that, so I'm not even going to comment on that, because effectively this is a public meeting, and while the investigation's ongoing, the last thing I would want to do is prejudice anything in regard of that. The third point is that obviously you mentioned there about racism and racism existing, and certainly at full council. I think that everybody at full council and everybody in this room today would agree with you that racism does exist in wider society. Obviously it does, myself included. So everybody in this room, I think, would agree with that. And unfortunately it does, for whatever reason. So in terms of full council, and in terms of myself as chair of Health and Wellbeing Board, you've got my agreement there. Racism does exist in society, unfortunately. And lastly, in terms of sort of like the pledge, I'm quite happy for officers to go away and look at that in terms of making an anti-racist pledge. I've not got any issues with that whatsoever, because as far as I'm concerned, I'm anti-racist. I don't believe in racism. I find it abhorrent. So from my perspective, I'll take that on board. The other thing that I think that needs to be took on board is the fact that when we get to item 7, you have got certainly Dr. Victor Joseph, and you've got sort of like my Director of Public Health, Rachel Leslie, addressing some of the points that you make in terms of sort of like certainly around the sort of like the improving certainly minority communities with where health is concerned. And the last thing I think you'd want to do, and that I'd want to do, is to speak in a professional manner for what obviously Dr. Joseph and what our Director of Public Health has done in terms of obviously progressing that. And I'm hoping that presentation to some extent will go some way to alleviate some of your issues and some of the queries you've quite rightly raised. So again, from my perspective, I'm looking with great interest in terms of item 7 and obviously what's going to be put forward for that. And lastly, I thank you for your question. You're always welcome at Health and Wellbeing Board. I understand fully that you are passionate. I've not got an issue with your passion whatsoever. There's a lot of work to do. And again, very, very lastly, I thank you for coming today. Thank you, Chair. Moving on to Minutes of the Health and Wellbeing Board meeting held on the 16th of January. Item 6. The minutes of the board last meeting are attached in item 6 on the agenda item. The board is asked to consider and approve these as a correct record. Can we agree that the minutes are a true and accurate record? Thank you. They've been agreed. Do we have a seconder on that? They're seconded. Thank you very much. Moving on to item 7. So again, I'm pleased that this has obviously come to the board today. This is the action plan for improving the health of minority communities in Doncaster. Rachel and Victor are going to present this, and obviously as a board, after the presentation, we're going to be asked to so like approve it. So I'll hand this over to Rachel and Victor.
Thank you, Chair. We have put this item at the start of the agenda, Mr. Ryan, in the hope that it would match with your availability. So this was an item on the agenda last time we met, and following comments from members of the public and from the board, we were asked to address 2 areas. So one was some questions around the context and the process to developing the action plan and the outcome from the previous action plan. So we will cover that between us. And then a second ask on detail and clarification within the action plan, including some of the actions to named persons as well. So Victor and I will work through a few elements of this. So we were asked about evaluation of the previous action plan, so we'll go through that. We'll come back with the key features of the health needs assessment that was published in 2023. That'll just be one slide. We wanted to describe the wider context of the questions asked about what else is happening around anti-racism in South Yorkshire and in Doncaster. Victor will then talk through the amendments and the conversations that he's had around the Minority Health Action Plan, and you've got an updated version of that there. We've included just a summary as well of some of the progress so far, and then what we want to do to address some of those gaps and new developments that we'll expect over time as well. So first of all, then, Victor is. So we're trying to make the thing work. So we just wanted to provide first a review of the previous action plan. So Victor.
Thank you. Thank you, Chair, and thank you, Rachel. So as Rachel said, the question from the previous Health and Wellbeing Board was around what progress has been made. There is a detailed report which was produced, and in one of the previous Health and Wellbeing Board, it was presented. So it is a public available document. Just to highlight some of the key points, we did take stock of the progress that emerged from the health need assessment action plan that we had. So key thing in terms of development was that there was this issue about addressing cultural competency, particularly during the pandemic. When we look back for a number of us who have been involved in response addressing the challenge of COVID, there was quite a lot of concerted effort, and members of the Minority Partnership Board undertook quite a lot of effort to try to reach out to minority groups in terms of the literature or video to communicate the message. You will note that the guidance are very complex. So that had been one of the positive things in order to raise awareness. Even, for example, uptake of COVID vaccine was a key issue. And I think that we noted great progress because of the concerted work that has been undertaken with the various minority groups, including, for example, key workers among Gypsy and Traveller group that had been identified in order to reach those people. And I think what members have said is to have the Minority Partnership Board was really helpful. People could come there in terms of share ideas and find a way forward in terms of some of the things that need to be addressed. It's kind of a place where people can come and discuss some of their concern or get some advice. So those are some of the key things I think, from the Minority Partnership Board in terms of what it is able to achieve. There were areas for development. During pandemic, we did have data to try to look at how are we doing in terms of minority groups, but we did highlight some gaps as well, which we needed to work on. And hence you will see also in the current action plan that continues, we continue working on it. The issue of community participatory research is important in order to kind of progress on some of this agenda. We need ethnic minorities to be able to participate in some of this research. And with the help of the Health Determinant Research Collaborative, which has got this approach of embedded research, we were able to kind of promote that initiative. And also broadening the outreach of the Minority Partnership Board so that we can get more members. So this is work in progress. During pandemic, the focus had been on COVID, but we have widened that to ensure that now there are some of the public health core issues that needed to be addressed. It could be smoking, could be obesity, could be mental health, access to health services. So you will see that the current action plan has picked those things. We did already identify there was racism and discrimination issue, and so this is an agenda which is still continuing, and you'll be pleased to know that there is actually a Doncaster Anti-Racist Partnership Board partnership which is currently in place, and it has agreed some pledges around around recruitment, around training on anti-racism, and around the messaging. And lastly, it is really saying that some of those agendas before COVID, which is now we're picking up, will continue.
Thanks, Victor. And we have bought a hard copy as well of the annual report on ethnic minority health. So that details as well the details that have been presented in that review. So just to move now, not to go into lots of detail because this came to the board around about 1 year ago, but this formed the basis of developing the action plan. So we completed both a desk-based element of a health needs assessment, but also some community engagement as well, to form an understanding of, one, how the demography had changed, so the makeup of our population, and how that had changed over time. We also used an understanding of the national key health inequalities relating to people from Black and minority ethnic backgrounds, and provided a summary there. And then we undertook some community engagement as well. There are gaps in community engagement, and we would like to do more of this when we are launching the action plan. And we'd like to use the recent model that we've used with the Muslim Wellbeing Conference as well to engage further with particular communities, recognising that they're not homogenous communities, and to be able to work with them on precisely how these health impacts exist within their own lives. And that will be particularly important for the action plan theme around access to healthcare. And then just the other bit about describing the broader context. So this isn't the only thing happening for both health inequalities and anti-racism and ethnic minority health and wellbeing. So for South Yorkshire, there is a 5-year equity and equality action plan for maternity and perinatal stage. RDASH have a clinical and organisational strategy of which inequalities and health inequalities features strongly. DBTH have published their first Tackling Health Inequalities strategy back in 2023, and have been starting with a programme of training for all of their clinical staff as well on how health inequalities manifest and appear in and on their wards and in their A&Es, and are doing some real focused work around inclusion health as well. After the needs assessment was published, we made some additional investment in our ethnic minority women's service, and you'll remember when we were preparing our strategy, our next strategy, we heard from the organisation Changing Lives that provides that for us. We have some dedicated workers with Gypsy Roma traveller communities, and just at the top there, so the Integrated Care Partnership provided an anti-racism update at the January ICP board as well. So I'm going to hand back to Victor again. So this covers the next section. We'll cover the ask for the additional detail and clarification around the action plan and where the responsibilities lie.
Thank you, Rachel. This is just to kind of update the board that we have worked on making the action plans smart. So it contains still the key themes there around the leadership and workforce, improving access to healthcare, access to adult social care services, translation and interpretation services, ethnicity data, and then building community. We have added citizens' advice to it, and thanks to the Chief Executive, James Wood here, who's kind of contributed a line there. We were able to identify key leads for each action. The block that is quite challenging is improving access to healthcare, partly because healthcare is not provided by one agency. There are so many organizations within that. We have agreed a key lead who will be working with the respective organizations. We have already identified some of the main ones, but work is continuing to kind of work with some of those leads. But otherwise, the action from the previous meeting to make it smart in terms of identifying specific work area and time bound are identified. And we will use this as kind of almost like the embed as part of terms of reference for our minority partnership board. So it will be kind of the regular basis how we would monitor the progress of this work.
So final slide then, just to cover some of the progress since we started this, the refresh of the needs assessment and the completion of the action plan. So I've described the additional investment in the ethnic minority women's group. We've got new focused roles, both place-based and community-based. So the Gypsy Roma traveller workers now have ongoing permanent contracts. We've employed a new public health officer in Doncaster team to work with communities on those, bringing the different communities together to focus on actually what does good health and care access look like. We had a session at the Health and Adults Social Care Scrutiny Committee, the most recent one, that we talked about health inclusion and the importance of applying an equity lens. Some additional progress and more to be done around the Minority Partnership Board, as well, including in membership and focus. And then that approach that we'll need to keep, so we'll have a published action plan, we've got names against it, but there will be new gaps that will emerge and new developments that we'll need to respond to. So being able to keep our action plan almost as a live and moving document, and being able to have our partners and our specific roles to be able to move the actions on within the action plan. That's everything I was going to cover. Victor, was there anything else?
No, I think
that's
you've
all.
covered everything. Yeah.
Thanks, Chair.
Thanks for that, Rachel, and certainly Victor. Just before we move on to any broader questions, I mean, just a couple of things that I wanted a bit of clarification on, if that's okay. So in terms of the Minority Partnership Board, are we confident that we've got a good spread in terms of organisations and individuals on that represents, and who are these individuals? Well, organisations really, to a large extent. And what I expect all organisations working on that board is that they've got a positive outlook in terms of obviously improving health, and to some extent, you know, they're still sort of like following that ethos around be kind to each other and work well together to ensure that people and groups are signed up to it as well. So that's first question, just reassurance that we've got a spread. The second one is around sort of like progress made to date, because it does obviously mention MPB development, and what does that mean in a bit more detail. And certainly in terms of addressing the gaps and new developments, I mean, we know that there is some gaps in it. I don't want you to have a crystal ball or anything like that, but I mean, what do you foresee as some of the issues that you know that this will have moving forward, particularly around, what's happening, lately sort of thing. So for me, that's sort of like my two questions that I've got on it to a large degree. I notice as well in terms of sort of like engagement, it looks as though you've got a list of organisations you've worked with, and that's Asylum Seekers, which is Conversation Club, African Community, Caribbean Community, Chinese Community, the Muslim Ladies Group, the Polish Community, and the Roma Community. Are there any other groups that you feel that you could work with at this time to bring into that? And that's me.
Thank you, Chair. Let me start with the last one. Yes, as Rachel said, those groups that we've worked with are those that we were able to engage during the process. And I think now with having dedicated community health worker or public health officer who will be, whose role would be kind of helping in terms of engaging with this. So we'll be reaching out to the other community groups that we're able to get access to. So this is going to be an ongoing piece of work, engaging with communities. And I think the mechanism we're thinking of is really to have those engagement so as to bring those voices into the Health Minority Partnership Board. So that's kind of one. And then your other questions around how do we envisage with the work around Minority Partnership Board development is we wanted to use this action plan as the focus. Hence, we want to have the key representatives, key organizations that are responsible for those to be around the table with the key persons who would report on quarterly basis. At the moment, from the experience of COVID, we've been meeting monthly, and this is between 5 and 6, almost out of hours. But we've designed that so that people who are maybe in their respective organization can be able to attend there. But it is obviously an ask from people to be able to contribute their time. So this has been going on for the last probably 4 or 5 years. So I think it's commendable for members of the board who have been there. So we would want to seek that engagement from the member organization to be around the table. One good thing around the Minority Partnership Board, again, we have embedded very simple values of respect, of honesty, as part of the function of the group. We need to respect each other if we're going to have conversation. We are bound to disagree here and there, but it must be grounded on basic things like respecting each other. So that is a very important thing we're going to focus on. Your first question, I don't know whether I've answered it. Remind me your first question. Yeah, the first one was just around the making of the board. Yeah, so the making of the board, it's those organizations listed there as part of the action plan would constitute the Minority Partnership Board. And a mechanism through the community engagement would be to bring those voices into the Minority Partnership Board. So there would be bound to be a lot. It won't be on those few that Rachel has shown on the screen there. There may be specific community, either country specific, that are here. For example, let's say Turkish community or Sudanese community and so forth, that are here in Doncaster. We might have not reached any one of them in a specific way, but this is a mechanism how we can engage with them and bring their voice to the Minority Partnership Board.
Okay, thank you very much for that, Victor. I'll now open it up to any other members of the board if they want to raise any questions around this item. Sarah?
Yeah, thanks for the presentation. I guess building on Mr. Brown's points from earlier, when we've got that slide with the list of the community engagement finding, and I appreciate this is a really brief summary of things, having the list on its own probably doesn't tell a story of how much of that community have we engaged with. So is that sort of 2 or 3 groups who have 20, 30 people coming to it? Is it sort of one group with 3 people and that's 2% of our community? So it just needs to be a proportionate engagement, and it'll be good to see that coming across, not so much retrospectively, but as we take things forwards as well.
Sorry, Nabil. Sarah.
Thanks, Chair. Yeah, I was just wondering, has this gone, have you communicated this back to the groups that you've been working with? Because I think that's one of the things sometimes that we, you engage and you get that kind of great information, and then it doesn't necessarily get translated back before it gets sort of passed. And I'm just wondering if it has, you've shown it, the groups that you've worked with, and any feedback from there, is that all in that report?
Yeah, a good question. When we did the first health need assessment, that was the very question that members of the community asked. And we then had to think how we can respond to that. And we suggested that would community representatives be happy to be part of the steering group? And we got a yes answer. And also over time, because people are giving their time and sometimes conflicting, their attendance in the board dropped off. So we are kind of open, but reviewing the best mechanism, how to engage on that. Part of the things is people saying, well, they're giving the time, the mechanism perhaps how to can incentivize people to attend this meeting. Or another model, as I've just said, is we would continue as part of this community engagement with those community feedback, what we are doing, and then also get back any suggestions of anything that we either missed or whether we're doing well and we need to continue on. So those two mechanisms will build into it, either a mechanism to get some members, willing members of the community to be on the board, or we will find a mechanism of continuous engagement with the community so that we can bring their voice to the Minority Partnership Board.
Okay, thank you for that. Anybody else?
Yeah, I just wanted to thank you, Victor, for taking on the feedback about adult social care. So I think last time there was a discussion, we thought that the leadership of adult social care, the nominated leadership in the plan, was a bit underpowered. So now we've got the service director, one of our two service directors, kind of leading the work of adult social care. So that feels like it's significantly strengthened our work alongside this plan. I also wanted to help or to have all these kind of questions about the scope and the focus and the communication around the people doing the work in this plan. But it also feels to me like we can't regard this plan as the limit of what we do around anti-racism and anti-discrimination in health and care in Doncaster. And that, to some extent, was reflected by Rachel talking about organisations and wider work that we've got, because I think none of us would say, oh, well, Victor's doing the anti-racism, anti-discrimination work, so we don't have to do it. So from an adult social care perspective, in January, Cabinet signed off, so Council Cabinet signed off our local account, which was the things we've committed to do for this year. As part of that, they signed off some things that they noted progress from things we did last year, which included our commitment to cultural competence, which we co-produced across our staff group and people who draw on care and support, and included an explicit commitment to anti-discriminatory practice. So not just saying racism is wrong, discrimination is wrong, but that we were committed to anti-discriminatory practice. And Cabinet also signed off 4 things that we would focus on this year in relation to promoting equality, diversity and inclusion as fundamental to day-to-day adult social care practice. So not a bolt-on thing, but fundamental to the practice. So those 4 things were understanding more about the people we support and our diverse workforce. So making sure we could, because we often find people in our workforce might have protected characteristics themselves, so how do we understand them better and support them better, as well as the people we support? That was the first thing. Second thing is a commitment to trauma-informed support. So recognising that people with protected characteristics have often had to carry and deal with trauma in their lives, and it's not necessarily straightforward for us to have a conversation with them. We need to spend time building trust with them. Third thing about creating deliberate spaces for people to connect with each other and build that humility and trust. So not have people on an assembly line of work where they've got no time to connect and work with each other. And fourth thing, and the council's done a lot of work in this space, so some of this adult social care work is piggybacking on wider council work, is to continue to support the diversity networks in the council that bring people with protected characteristics and their allies together to provide support and influence policy. So I suppose support the plan, and it's good the specific things in the plan have come from people with lived experience in that group, but also to recognise there's wider work that we're doing as part of this commitment as well.
James?
Yeah, thanks, Victor. It's a really great plan and we're proud to be part of it. I guess my question is, do we do enough in terms of socialising the good work that does go off so that people in communities know the hard work that we're undertaking and the tasks that we've done? And by championing the work and the plan, would this improve engagement and trust in what we're doing and the ideas that we're trying to push forward?
So yeah, this is something that we do want to strengthen. We think there's a HDRC Health Deterrence Research collaboration role and function as part of this. So I've mentioned a couple of times the Muslim Wellness Conference. So that was a chance to design an approach to how you would have a community-led event, conference that provides a safe space for a community to come together to talk about wellness in a community. We had embedded HDRC workers within that doing a piece of kind of ethnographic research as to how that is established. Also around that as well, and it won't be right for every conversation or every grouping, but we're able to profile that work as well. So when they come together again, it's drawn in more members of the community who want to be part and to participate in it as well. So we're almost developing a toolkit approach or a way to try and improve, yes, the recording of what was learned and what was a good aspect of how we brought that group together, but also how we share the positive elements that come out of it as well, and hope to apply that similar but tailored blueprint to all the next stages too.
Okay, anybody else? No?
If I can add to...
Sorry, go on, Rick.
Yeah, if I can add to James's point, even within the minority partnership boards, some members have kind of recognized the work that has been going on. And as I was saying, since we did develop the first health need assessment, we started meeting every 6 weeks, again, trying to see how we can take this forward. And when COVID came, we were meeting almost every week and then every 2 weeks. A lot of effort has gone in to try to improve and protect the health of minority groups. And it has been recognized by some of our members in the health system that really this is a commendable piece of work. And I think we need to kind of build on that. We need a process of continuous improvement, essentially, in terms of we will do certain things right. There's certain things that we might have kind of, people will let us know that, oh, this is missing. We need to adjust our plan and continue on that. And I think also sharing with other people in the region, because people are coping, I've seen the good thing happening in Doncaster, and they would want to see how we can take that forward. And then the point about Phil mentioned is correct in terms of making sure that what we do kind of connect to one another. There are a lot of good work happening. It's not only minority partners, but particularly around racism and discrimination. I did mention in the last year there has been a group around Anti-Racist Alliance. It contained all the major organizations in Doncaster, the council, the NHS partners, and St. Ledger and so forth, which I think is a good development. It's kind of undertaken 3 pledges. And those 3 pledges are, and that's a start around training on racist agenda, and it's around also how we communicate those messages and recruitment.
Okay, everybody okay with that? So just a couple of last things from me really around it is that I think it's obviously sort of like a very pertinent issue, certainly for this board, in terms of sort of like taking this on board, and there's been some very positive work done so far with it, so that's great. What I would like to see though is I would like to see potentially in 6 months' time a bit of an update from yourself, Victor, obviously sort of like Rachel, in terms of how it's progressing, where we're at currently, you know, with it at that point. So if we can obviously put that in, that there's some feedback in terms of how it's developing, that would be really, really good. The second thing to me is, I mean, call out is to organisations. Obviously, Victor's made it perfectly clear if any organisation wants to be involved with it, they can do, but there needs to be that mutual respect and there needs to be that buy-in to that code of conduct in terms of working with people positively. Okay, so the recommendation is, can we ask the board to endorse the action plan for improving the health of minority populations in Doncaster? Is this agreed? Okay, thank you very much for that. We'll now move on to item number 8, and it's working in partnership. Unfortunately, Gavin Boyle, who's Chief Executive of NHS South Yorkshire, isn't able to attend this meeting. He was due to be here today to provide a report in terms of working in partnership. I'm still keen that obviously sort of like Gavin attends at a future meeting. So if it's okay with you, I think we note the report that's in the pack, but we also ask him to come back to a future meeting to obviously provide this report as well. So is that okay with everybody? Yeah? Okay, thank you. So moving on to item number 9, Health and Wellbeing Board terms of reference. This is in the pack as well, but I'd like to obviously bring forward Claire Henry now, who's going to talk about this for 5 minutes before we potentially review and endorse it. Thank you.
Thanks, Chair. So at the last Health and Wellbeing Board back in January, I highlighted that we've got the opportunity to revise the terms of reference in readiness for approval at full council in May. So that work's taken place and the draft of the terms of reference is in your agenda packs. They've been refreshed to reflect all of the work that's taken place over the last 12 to 18 months in terms of the development of the new Health and Wellbeing Board strategy, but also the ways of working and some of the principles that we've articulated in that strategy. So the terms of reference have a focus on the wider determinants of health and those building blocks for good health that we've described in the Health and Wellbeing strategy. It also includes those statutory responsibilities that the Health and Wellbeing Board needs to undertake, and also includes now the membership of the board, both the statutory responsibilities and membership that has to be in the Health and Wellbeing Board terms of reference, but also those locally determined members that we can choose depending on our local context. That membership has a difference in membership is around people's posts, but also it can be representatives of different organisations and forums as well. So you've got the information in your packs, so I'm more than happy to receive any feedback, Chair, to be able to then seek approval for endorsement to be able to take forward to full council in May.
Okay, so any member want to comment on this before we go to endorsement? No? Okay. So the action is basically that we effectively endorse this and then it'll go to sort of our full council for ratification. So is everybody happy with the revised terms? Is that agreed? Okay, thank you very much for that. Thank you, Claire. Moving on to item number 10, it's the Director of Public Health Annual Report. It seems ages ago this, doesn't it now? Rachel Leslie is going to sort of like give us a brief on this, and we're asked to note the report, but it'd be good obviously to hear your spiel on it, Rachel.
Thank you, Chair. So those that were at full council in January will hopefully recall this was presented then as well. So Directors of Public Health have a duty to publish an independent annual report on the state of the health of their population each year. In Doncaster, this report is presented at full council in January, and it's usually provided for information to partners, including to Health and Wellbeing Board members. The reports generally have a standard outline. They select a topic, they include analysis of data, you always include a description of the use of the public health grant over the previous year, and there's a series of either reflections or recommendations. Over the last 3 years, in order, the reports have been on quality of public health services. The previous years was on children's and young people. And then this year's has been on Doncaster's health determinants research collaboration. So our report for this year, the 2024 report, focuses on research approaches to improving health and well-being and to reducing health inequalities. I just wanted to highlight why I've given a kind of summary of the last 3 reports. So the previous one was on children and young people. That's obviously one of our priorities for the Health and Wellbeing Board. And then our third priority as well around healthy places to live, grow and play. And as you've looked through the report, I hope you spotted that the data section is around the positive things that we've done so far, but also some of Doncaster's data around natural built environment, spatial planning, air quality. So the report, why did we choose health determinants research collaboration and research approaches? So the report was written to celebrate the 2nd year of Doncaster's HDRC. Doncaster was awarded one of the first HDRC funding, and this was following a competitive process. So Doncaster became one of the UK's first HDRCs back in 2022. The aim of a health determinants research collaboration is to bring investment in to develop a research infrastructure, and that's over 5 years. So bringing the report today really for information, but for discussion as well, because it does provide some of that data and background around healthy places to live, grow and play, one of our 3 priorities of the new health and wellbeing strategy, and describing those building blocks for good health as well. So the investment that has come in for HDRC recognises that health is more than just health services, that we establish the building blocks of good health in other public sectors and in other things, in the connections that we make and in the environments that we live in. So data section, if you've had a chance to look at it as well, talks about natural and built environment, spatial planning, and talks about active transport and air quality as well. And just to summarise at the end, 3 recommendations. 1 around research infrastructure and the difference that can make to how councils and how areas work. The benefits of liberated approaches or providing staff or providing people with time to pursue questions and research curiosities about the work that they've got. And then the third, which matches to our third highlight in our health and wellbeing strategy, which is on focusing on creating healthy places to live, grow and play. Thanks, Chair.
Thank you very much for that, Rachel. Just before we move on, I mean, we're asked to obviously sort of like note the public health report. Before I sort of like bring any members on that may want to sort of like address this or raise any queries or concerns, I just want to thank obviously the public health team, and in particular sort of like Susan Amshaw for the work that she's done with HDRC and obviously working with partners over the last couple of years. It's been absolutely fantastic. It's been a really good advertisement for Doncaster, and I know they're doing some really solid work. Does anybody want to come in at this point? Sarah?
Thanks, Chair. Yeah, just to basically echo what you just said there. I think it's absolutely incredible getting this time and embedding that kind of research culture into our workforce and the council as a whole. I've been incredibly lucky myself to be chair of one of the projects named in this report, which on the so I chair the strategic part of the Creative Health Boards, which has been an amazing learning opportunity, and to see how our embedded creative researchers are working with community members specifically has been brilliant. And I think it's great, and we get to work with Lucy a lot on that, and being able to kind of bring methods that really connect with people in place and then make them a huge part of that kind of research journey and what matters to them, as well as getting really good health outcomes, really has been a joy, and I'm great that we've been able to secure that. And research is such a huge part of being able to maintain your workforce, because it gives them creative autonomy. It allows them to use reflective practice, which means they can see, they encounter something consistently, or if there's a kind of like a gnarly issue that won't, you know, you're just like, I wish there's just some way that we could work this out. Research gives you that space, and I think this is just going to build our momentum and really put Doncaster on the map in terms of being an open and ambitious, person-centred council. Thank you.
So, thank you for that. Do you want to come back on that at all, Rachel?
No, but I'm just wondering, so what the comment about staff retention as well is highlighted in the recommendation. So enabling and protecting staff time, and one of those benefits is around that staff retention element as well. So thanks, Sarah.
Nabil.
It was just a question of, I was just having a look and it said about how the topics are selected. Is there still more topics that can be added, or are we past that point? Because I've got a suggestion if there is, but obviously I won't say if there isn't.
Is this for future topics of Director of Public Health annual reports, or is this future topics for research?
Research.
Yes, there is, and it's help at HDRC, so I'll get you the details afterwards. So yes, there is.
Yeah, I mean, it's probably just worth noting here. I wonder about the sort of the ketamine bladder stuff we're seeing in children. If that isn't already on the agenda, that feels like a really key one.
Yes, it is. So generally the HDRC funding is to build research infrastructure around the causes of the causes, but we have had things like youth vaping as well. We've had HDRC input and support too, and the ketamine bladder and ketamine use is definitely one. And I'm checking behind me because Simon is nodding enthusiastically as well. So yeah, absolutely. Thanks, Nabil.
Okay, thanks for that, Rachel. Anybody else? No? Okay. Well, I mean, obviously the recommendation is to sort of like note the report, but from my perspective, again, I just want, as chair, to put through a formal sort of like voice of thanks from myself in terms of the work that the public health team have done with this, but also in terms of the partners, very, very varied partners that we're actually working with on it. So, are we happy to note the Public Health, Director of Public Health report? Is that okay? Yeah? Okay, fantastic. We'll now move on to item number 11, which is the Health Protection Annual Report. Victor, you're on again. You've got 15 minutes to talk about this. It's very interesting. I read it this morning while I was having tea and toast, so if you could do it some justice, that'd be great.
Thank you, Chair. This is the annual report on health protection. We have been producing this annual report for more than 10 years. Since public health moved to the council. So it's been fascinating. Also, we have annual session with the scrutiny panel, but it's good that it's come to this board as well. It has been in the form of minutes of the quarterly meeting, but I think it's great to see that a bit of the annual report coming to this meeting. The other thing I want to say is a lot of work from a lot of people in the system that has that formed this report. You will see that there are several scope of health protection. In the interest of time, I'll just pick up some of the key ones here, but the details are in the report in terms of the scope of the health protection. So key highlight here is, I'll talk about the scope, I'll talk about the infection prevention control, about the MMR and pertussis, screening and sexual health services. So you can see the breadth of the scope of health protection. When public health moved to the council, the first thing we did was to agree on this scope, and we worked together with our counterparts in South Yorkshire as part of mechanism we're working. So it captured emergency preparedness, resilience and response, infection prevention control. TB is part of the infection, but it stands alone because we have a steering group on TB. Some of you might have probably not heard much about it, but actually it's keeping our workforce, particularly healthcare workforce, very busy. And we are seeing an increase in cases of TB. Air quality is very important. Again, working with our colleagues in the place. sexual health, substance misuse, suicide prevention, again, another very important area of work. And then lastly, immunization and screening. So I'll touch on a few of those rather than all of them. One is infection prevention control in the wider community. Though I picked this one, we also included infection prevention control in our 2 hospitals, DBTH and RDAS. But this particular one is important because Public Health in the Council and our ICB colleagues, we commission this service. At the back, we have been doing that for a while, but during COVID particularly, we faced particular challenge, and all the system had to pull together how to address infection prevention control. And emerging from COVID, partners have agreed that we need to maintain that model. It has served us very well in terms of proactive work, working with care homes, learning disability homes, supporting living and extra care facilities. Our IPC, or that is IPC Infection Prevention Control team, have worked very hard and proactively and reactively as well when there are outbreaks of infection. I put some figures there. For example, over 800 routine face-to-face visits that they've done throughout the year. That's quite incredible. And there are ongoing monthly educational session, awareness session. You will find that there are turnover in the workforce in these care homes. And therefore, it's important to continue this educational session, particularly when you got new managers, they'd have to get used to the new policies and so forth. Relationship is quite good across the system. And we have, because we have these services across South Yorkshire, probably elsewhere, Doncaster stand out as example of good practice in how we have commissioned our IPC service. MMR and pertussis have been a key feature here, partly because we had, last year, we had some cases of measles. We have outbreak of measles, and this followed a pattern across the country and elsewhere in England, and then subsequently also in Yorkshire and Humber, and we had our share. It's been managed, but as a result of that, and even before that, we anticipate that it was a question of when rather than if we're going to have an outbreak of measles. We recognize that our uptake was not as high as it should be, so we set up a vaccination cell, and this cell has been meeting monthly, and it was very helpful working with our primary care colleagues to see how we can be able to improve the uptake of vaccination, particularly picking up our unvaccinated children who are supposed to be vaccinated and working with our practices to see how we can be able to improve that. But also our community settings as well, how we can amplify some of those messages. So this is an ongoing piece of work. We've added pertussis because we realized that our uptake of pertussis vaccination also was quite low among pregnant ladies. So you can see that our uptake, it used to be historically well below 90, that is MMR1, that is within 24 months. But we have some improvement now, over 90%. The WHO recommended target is 95% to achieve what we refer to as herd immunity. That is, if we get 95% of the population covered, the 5% will be protected. So this is an ongoing piece of work, but we are pleased of the progress that has been made. And we realize that still we need to continue on that trajectory. I wanted to highlight breast screening as one of the challenges. You will see that at the bottom there in that small table, we have 66%. We're supposed to have an acceptable level of 70%, at least, or 80% achievable target. This has been picked up by NHS England as an area that needs more work on. There is some national campaign, similarly some local work which is going to address that issue. So I just want to kind of bring it to your attention that we are aware of this in terms of women's health. We need to work to improve that performance. Sexual health, again, very important area. There has been some challenges. The key one I want to highlight is in terms of workforce capacity. There has been turnover in terms of the specialist consultants who manage the service, but the service has been kind of sustained through the locum work, but I think efforts are going to recruit that. The other thing is in terms of increase in syphilis cases in Doncaster, particularly among commercial sex workers. There has been outbreak control meetings to manage that along with our other partners. You can see that a range of service under sexual health service that public health is undertaking to test for a range of infectious diseases such as hepatitis A, hepatitis B, human papillomavirus, and so forth. So I think those are the key ones. You will note in the report there are also suicide prevention work going on, which is by itself, it's got a steering group that is working on that. A lot of work going on that. From experience, leading also in some years ago around the same agenda, it's a very difficult and sad situation. For every suicide, you will find more than between 10 or 20 people affected because of one suicide. So we give credit to our team who are working and leading this piece of work. Thank you, Chair.
Okay, thank you. So before I bring anybody in, I just wanted to sort of like cover a few points myself, if that's okay, if you'll indulge me. So I suppose areas of concern that I've got is around some of the preventative work. So if we look at, for instance, MMR vaccine, in terms of, I suppose what I'm wanting to do is to get a bit of a feeling from yourself in terms of whether that is improving, it's likely to improve, or is there a mentality out there in terms of sort of like people turning around and saying, actually, we're not going to bother getting vaccinated, you know, almost like we're anti-vax. So I am concerned about that. But also in terms of screening to a large extent, particularly around breast screening and obviously sort of like cervical screening as well. So when you look at the full report, which I've done, as I say, this morning, my concern is, and I'm going to use this terminology because it is allowed, because it's actually in the formal report, is that when you look at where we are in Doncaster, which is 6.8%, and we look at what's acceptable, and that's 70%, clearly we are unacceptable in Doncaster in terms of what we're doing, and that's particularly around breast screening. Now, when you look at the Health and Wellbeing Board and you place it against our 3 areas of focus, and one of those areas of focus is clearly sort of like women, and women's health and improving women's health, there's a fair bit of work to do there, because I'm not being funny or anything, but it is unacceptable. We know what the ban range is in terms of what's okay. That's not okay. We need to improve that. So looking at the improvement work that's happened since then in terms of sort of like that bit of a charge in terms of getting people looking at breast screening. Do we know how successful the campaign has been? Certainly for the last couple of months. Has that worked effectively? And is that going to continue? Because in fairness, we're letting down a lot of women where this is concerned by not encouraging it, not just for that 2-month action plan around obviously raising awareness. We should be doing it all the time to bring us up to that. And again, looking at it, we know that our most impoverished, deprived communities suffer greatly in terms of sort of like ill health, and effectively this will further compound them. So I am obviously, you know, interested in that. And again, when you look at obviously sort of like some of the screening that's around, just bear with me a second, just flicking through. cervical screening, for instance, I mean, it doesn't use the acceptable or the unacceptable point in the report for that, but you look at obviously sort of like Doncaster being at 71%, and we can see there that effectively the target is 80. And again, my concern is that, you know, because again, our priority is improving women's health, we should be obviously playing a greater more focus on that, you know, to ensure that people are undertaking that screening. So I suppose that's all I've got, you know, just on that before I open it up to anybody else.
I'll come in on that if I may. So as Victor described at the beginning, health protection is a real multi-agency role, and the role of public health teams in local authorities is one of assurance, so to be assured that the systems and that the things are in place, and to make challenge where we don't feel that they're up to scratch. If Anthony was joining us today, he would be able to give all of that detail and background behind what's happening with the vaccination programmes and with the screening programmes. But just wanted to share a few bits based on what you've said. So we have mobilised a small amount of funding that we've received additionally in Doncaster around women's health hubs, and you'll have perhaps seen hopefully some of the promotions around there. So we've used that for the health vans to go to particular areas in Doncaster and to actually provide screens on the vans. Now, I was a bit concerned. Me personally wouldn't think about getting onto a van to have a cervical screen, but it's been really successful. So good number of screens and a good number of people that either haven't been screened for a long time or have never been screened at all. So I'll eat my words with that. So we are able to direct those kind of personalised approaches. And again, we learned this in COVID. You've asked about the impact on vaccination. There has been a change in vaccination rates. We've always known that in a population you will have people that will go along to their routine vaccinations. There's a group of people that it's really difficult to get to them, so the practical side of them, matching an appointment time to being able to get to it. But there are a group of people that are uncertain as well and need those usually one-to-one conversations with a clinician about the benefits of that vaccination, or as we saw in COVID as well, conversations with people from their own community. So whether it's assurance around possible poor signs, so pork ingredients in a vaccination, whether it's a cultural or religious, or whether it's about a fear or something that they've read. So that one-to-one relationship to support vaccination uptake is crucially important. You've mentioned anti-vaxxers. There will always be a small group of people who choose not to have a vaccination, and that's why, again, it's so important to be able to maintain or get to that herd level of vaccination through the rest of the population. We have seen cases of measles last year, so we had a couple of sporadic cases of measles. Measles can be deadly, can make a child very unwell, and it does cause death. We were able to respond really quickly. One of the other things that Victor included in his presentation was the commissioned Infection Prevention Control Service. It's unusual for a local authority public health team to commission, to fund a service like that. We stepped it up in COVID and we've retained it because it's important to keep residents and staff safe in care homes, but they've also been able to work super flexibly with us, so helping us with that measles situation, being responsive when we had an avian influenza case, but also participating in our Remake Learning Festival and doing hand washing with kids as well. So we've been able to focus that prevention element. On that assurance piece, so you've got the full report here, the one that will go to scrutiny. The report has grown because the breadth of how we describe health protection has grown and developed over time. And I think Victor and I have talked as well about would there be other audiences that would want to comment on the assurance that we're doing as part of a health protection assurance group too. So hopefully that's answered some of those questions around vaccination and screening.
Yeah, so from our perspective, we're not ever a case of sort of like placing it back on the relevance of public health. I mean, it's just a pity we haven't got any colleagues, obviously, here from the health service here today to sort of like deal with some of those concerns. Anyway, anybody else who wants to raise any questions?
Yeah, I just wanted to say, I mean, thank you for raising about women's health, and it's something very close to my heart and my personal experience, particularly about breast screening. what we've always found as well, that it's not just an health response that's needed, it's a community response, which Rachel was touching on. There's lots of barriers for people that we work with, and I think that the community organisations are really well placed to be those people that can support women to their appointments, to talk about their lived experience with them. So I'm just thinking any approach that we have around these campaigns, we definitely need to have the voluntary sector included, because a small amount of resource, sometimes just the price of a bus fare is the difference between a woman getting screened or not getting screened. That's all I wanted to raise. Thank you.
Thank you for that, Kelly. Nabil, I weren't placing it on your head either, but you're welcome to come in on this if you want to. Sarah, go on, Sarah.
Just to, echo what both Chair you said and Kelly, we noted one of the things I think that could help us is that a lot of, so I got this training because Councillor Ball and myself have been really interested in the uptake of breast screening and cervical screening for a long time. It's been about 2 years, right, Nidge? Of which I feel like we're not fully getting to the root of it, to be honest, because it's been 2 years and it's not, I'm fairly sure it's getting worse rather than better. And I got trained to look at the data on the integrated care system of so you can get the data at a super local level, can't you, of neighbourhoods and GP practices about who's not doing their cancer screening tests. And so I went to my GP, my local GP practice, not my GP practice, because they were quite low. And they were really responsive, but they had no idea because they were looking at data where basically if you send out free reminders and you don't turn up, they go, oh, well, we've done our job, tick, we get the money. So they were like, well, we're at that target level. But actually, they weren't aware that there's still quite a significant amount of people not coming forward for their screening. So they were really responsive, and they actually got a login to look at that data so that they can start changing their practice. And we worked locally with a food bank is a trusted organisation, and we got they used some of the Doncaster cancer communication money. And we managed to get 12 people that hadn't been screened in 10 years or something, which I thought was really good. But it just goes to show, it was really trauma informed, and it was fun as well. There was a fun element. They kind of ran with it. They did stuff that I don't think I would have necessarily, didn't even know I'm quite creative. So they had t-shirts made and things and cakes with all the women genitalia on. And it worked really well, and it really built that trust. And I think that's the kind of stuff that we need to really get going. And I'd be interested as well on this data about people from different ethnic groups represented in that. And we also know from research and data that it is those living in more deprived communities which are going to turn up more advanced disease and more likely to then, have more challenging or poorer outcomes of their treatment. And so given the life expectancy and the, healthy life expectancy of women in Doncaster, this feels like it definitely is a priority, and it needs to come back to Health and Wellbeing Board with a proper brief. I also note that the hepatitis A stuff in your report, and that's another problem that I've had as a local councillor, where residents have been trying to get their Hep A vaccination for foreign travel, and a lot of GP surgeries aren't taking them up for it, and then they can't even go private because it's supposed to be free on the NHS. So it's been quite a challenge, so I think that might be something to look at. And then I also know that there's been quite a few breakouts of hospital-acquired flu and COVID, and all of it talks about cleaning, but not air flow. And we know that COVID is a airborne disease. So I'd be interested, if maybe get a written response from the hospital or something. If we can start building in proper like air filters into DRI as a protection thing, and also I spend a lot of time there at the moment, and people don't really wear masks, so I think when there is a high rate of in that wave, it would be quite good to kind of if possible get staff to wear more masks. Thank you.
Okay, thanks for that, Sarah. Nabil, did you want to come in?
Yeah, a few things. We are light on health representation today, but I am still here. So a couple of things. So I'm glad the earlier points around the breast screening. That was one thing I was going to say. I was going to ask, and I'll take this into our sponsor session afterwards, because I'm one of the Women and Children's Gaps sponsor, is do we know why we're low? So obviously if we come up with a solution, whether the national campaign is going to work, what we want to do locally, but fundamentally, do we know why we're low? And if we don't, we need to find that out quickly and using some of the engagement stuff we've talked about earlier. In terms of what I wanted to mostly say was that there is a new GP contract that has been agreed for the first time, I think, in 4 years. So it's been imposed the last 4 years, but this new contract has been agreed for 25, 26, and there are some changes from the vaccination side of things for children. So that's a really important thing for us to note. And I think it probably is important enough that we may want to, whether it's one of the focus areas within the Women and Children's side of things. But just to give a rough idea, is that the item of service payment for each vaccination is going up to the GPs. So there's an increased incentive to do so, but there is a fundamental change in when some of the vaccinations are being given, including MMR, and there's also going to be varicella chickenpox vaccination for the first time. So actually, it's a really important year, I guess, in terms of how that all lands. All the stuff we talked about, vaccine skepticism, how much of that will affect the uptake of that, and it feels like a real opportunity to do some partnership work between the GP practices who'll want to hit the targets and get the additional funding for doing so, but also there is some stuff we can do as individual GP practices, but there's a lot we can't do, which again is all the stuff we said about the community, the public health side of things. So we've done little bits of it around pertussis and MMR, but actually it feels like this year is a time to really look at it and do it in the same joint way we did around COVID. And then just the third little point, I went to the we had a health inclusion event around A&E and particularly sort of vulnerable groups, and one of those was around the syphilis and sex workers. And actually, one of the points I highlighted to one of the presenters was there was a comms that came out to GP practices 6-9 months ago saying, think about syphilis, with this long range of conditions, because it's one of those things that presents not in a very typical way, lots of different things. But actually that hasn't been followed up with further comms. So as a GP, when you get a one-off comms, you might not read it, but you get it. Even if you read it, if you don't have further comms, you don't know whether that outbreak has settled down or has got worse. So actually, for me, as a well-informed GP, I didn't realise that things had got worse. So one of the bits of feedback I gave to that group was we need to get another set of comms out, general comms to all practices, but particularly targeted at those ones who are in the town centre.
Okay, thanks for that. Rachel, you want to come back?
Yeah, so particularly around the syphilis, so yeah, we continue to have higher than expected number of syphilis cases in Doncaster. Where we've been testing, it's been allocated, or it's been identified in a particular group. We would like to begin a new approach to see whether it's wider in our wider population. We suspect it probably is. The slide that Victor presented earlier around our sexual health service, I'm looking at Simon again. So we have had challenges over the last probably 18 months with our sexual health service, not on the provision that they give, but the general shortage of GUM, of sexual health consultants and their availability. So our provider has been working really hard to secure that consultant cover, which is now in place. So now that we've got a more settled sexual health service, we do want to do a campaign about syphilis, which will hopefully bring more people that could have potentially been exposed to syphilis in for testing, in for contact tracing, and then in for treatment as well. But yeah, we will continue with that comms, because it's likely that you will be spotting people, or in a good position to spot people with symptoms as well. Thanks. Yeah.
Go on, sorry, Ruth. Ruth, can you just press your microphone? Sorry, yeah, you're all right.
Okay. Sorry, Kelly. Yeah, apologies. So just in Anthony's absence, some assurance around some of the areas of focus, I guess, from a cancer perspective across Doncaster. And just a couple of points to pick up on. One is around a South Yorkshire-wide strategy called Shows Up to Cancer, which is really having a focus on that preventative and screening angle, and working in particular with employers across South Yorkshire and Doncaster. Working with employers of kind of large employers and small employers with regards to awareness of their employees around the many different cancer types that we've got. And then the other is around something called timely presentations. And some of the great work, I guess, that's been happening from a community level. I'm looking at Kelly from some work that happened at the People Focus Group. So with a really small amount of funding, some voluntary sector organisations across Doncaster have really done some great work. I think Sarah alluded to those as well, in terms of awareness of cancer, recognising the signs and symptoms of cancer, and supporting people through to cancer screening. So just to reassure the board that there is a very firm focus on cancer prevention and screening, but obviously some way to go, and working with communities is actually, we need to do much more of that in the future. So just some assurance.
Yeah, and just to say, I mean, there were no way I wanted to sort of like put yourself or Nabil on the spot in terms of this, because I think it's wider than that. And I were hoping, Anthony, we're going to be here to obviously sort of like address some of the questions. However, I think you make a really valid point, and I think Kelly's made a valid point in terms of the information, advice and guidance that can be passed on in those really gentle, everyday conversations you can have on a community level. So I see this to a large extent as chair as not just being the, I mean, obviously the actual sort of like the hard works of it in terms of the screening, and certainly some of the work that needs to be done is NHS led, but the preempt to that, to enable an individual to have confidence and obviously give them the go ahead to do it. Some of that needs to be done in the community, and we've all got a role to play in that, in fairness, and we do that on a day-to-day basis, or I would have hoped so, you know what I mean, to a large extent, because those simple conversations. Well, maybe you need to go and get checked out, maybe you need to do this, maybe you need to, well, why don't you, over a cup of tea, it can make a massive difference. So I take that on board totally, and thank you for that. Any other comments on this report? Victor?
Just to respond to some of the comments or questions made, based on the experience of the work we've been doing around MMR, there are some two key lessons. One is around the data. We need to get that right, because if you don't get the denominator right, you don't get the right figure. So, for example, there are people, the children who are on the list, but they may not be in the practice. They've left, but they cannot remove them from the denominator. We need to understand those. For safeguarding reasons, they've not been removed, or they are not being removed from the count. So that affect the uptake. The second lesson is people have touched on, we need to be a bit more innovative. In the sense, some people, and deprivation play a big part of it. some people may not turn up to GP appointment, not that because they don't want it, but because of the circumstances they find themselves in, they are not able to turn up to those GP appointments for those. And the suggestion which I'm hearing from colleagues was around community settings. How can GP practices work together with community? We've got, for example, Doncaster. We started that conversation having, for example, fair or community events where we can bring some of those vaccination into those settings. But we need to work on the challenges, because GP practices work on the basis they order the vaccination for their patient. They wouldn't give it to any other person. Although we hear it's possible to work across more than one GP and even across PCN. That is an ongoing conversation we are starting to explore. If we were to have a community event, people turn up, can it be given there, regardless which GP you are registered, as long as you're in Doncaster, it can be given. So it's this kind of innovative way that we need to explore. We know it has been done elsewhere. So it can be done as well in Doncaster.
Thank you for that. Anybody else? Nabil, go on.
Yeah, just to come in on the back of your points, Chair, I think it's not that community has a small role in this, it's that community's got a massive role in this. So I think, there's the awareness and the confidence and the trust, but it's also going with people to appointments. That's a huge thing as well. So, and I hope that all plays out in the Thrive work, the VCSE work, but everything. But it's that holding the hand for the person who wouldn't attend otherwise is really big, and we can't do that as GP and as health services. That's where we need the community to step up.
Okay, that's fine. I think we've pretty much exhausted that, aren't we? Just to sort out, the board is formally asked again to endorse the Health Protection Report 24-25 for Doncaster. Are we agreeing this today? Is that okay? Agreed? Okay, thank you very much. This is the end of the meeting now. Obviously, there's the informal session in terms of sponsors after this, so anybody who's taking part in that, I'll give you a chance to go and get a cup of tea and obviously nip to the loo. But from my perspective, the next meeting we've got planned is on the 5th of June, 2025. We all know an awful lot can happen within these next 2 months, and I just want to say thank you very much for having me as your chair, and it's been great working with you. Cheers.